This is Professor Tomas Rogula, founder of the IBC, and I am delighted to announce today we have another IBC University of Oxford Surgery webinar to be streamed via the IBC website www.ibcclub.org. The IBC University of Oxford webinar series is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars are to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford have allocated September 15 to 17, 2026 as the dates for the 7th IBC University of Oxford World Congress to be held at the Examination Schools, University of Oxford. For more information, go to the IBC website www.ibcclub.org. We would like to thank our global education partners for the 2026 IBC University of Oxford webinar series, which are Bariatric News, the International Obesity Society, the Upper Gastrointestinal Surgical Society, Laparoscopic Surge, Bariatric Channel, the Robotic Global Surgical Society, the Operating Room Global Foundation, and the Gulf Obesity Surgical Society. We would also like to thank our platinum sponsors Johnson & Johnson MedTech, Reach Surgical, XNY Medical. Gold sponsors Medtronic, MyConvey, ConMed, Carl Stores, Standard Bariatrics, Teleflex, USGI Medical, GI Windows, Silver sponsor Azisort Medical, Arabian Co, Bronze sponsor Intuitive. I would like to now ask the webinar chair to open the webinar.
Hi, everybody, and welcome to this IBC Oxford webinar regarding bringing reliable vessel sealing to robotic surgery. I'm Paulo Bernante from Italy. I am an associate professor of surgery at the University of Bologna, and I am the chief of upper GI and bariatric and metabolic surgery unit. I'd like to introduce our moderators, who are Dr. Maria Altieri. She's associate professor and section chief of gastrointestinal surgery and director of bariatric surgery at Penn Medicine, Pennsylvania Hospital from USA. Then we have Dr. Hany Takla. He is attending robotic bariatric and general surgeon at Orlando Health Weight Loss and Bariatric Surgery Institute, Florida, USA. And last but not least, Professor Shaneeta Johnson. She is a chair and professor of surgery, Department of Surgery, Meharry Medical College, Tennessee, USA. She is Associate Dean and Vice and VP of Global Health Partnership and Engagement. She is Professor of Global Health at Meharry School of Global Health, Tennessee, USA. And I give the phone to Professor Maria Altieri to introduce our first speaker.
Thank you so much, Dr. Bernante. Thank you for the kind introduction, and it's a pleasure and honor to be here. And I'm very excited to introduce Dr. Isabel Mesquita, who is an attending general bariatric metabolic and upper GI surgeon at Santo Antonio, Portugal. She's also an assistant professor in medicine, School of Medicine and Biomedical Sciences at the University of Porto in Portugal. She will be giving a talk on the risk factors and catastrophic consequences of poor vessel sealing in sleeve gastrectomy surgery. Professor Mesquita.
Okay, so I will share. Are you seeing the screen? Okay. So good afternoon. Thank you for your kind introduction. It is a real pleasure to join this forum in the different role than usual, from follower to speaker, especially in this panel of colleagues and friends that I had in this robotic journey. So my topic is by design introductory to the others, and I will focus on why poor vessel sealing in sleeve gastrectomy matters clinically, how and where it fails, and how a small technique imperfection can escalate into a catastrophic cascade. So the goal was to build a clinical rationale that naturally leads us to the need for more reliability technology, especially in the robotic environment. So I will structure this presentation in 4 steps. First, clinical framework, why sleeve, why bleeding, then a root cause analysis, then the complication cascade by bridging to innovation, the topics of the next speakers. So let's start with a big picture. Obesity, as you know, is a global public health challenge, and bariatric and metabolic surgery has become a cornerstone of effective treatment. And because of this field is so high volume, our tolerance for preventable complications must be extremely low. So sleeve is the most performant bariatric procedure worldwide, as you know. That matters for 2 reasons. First, reproducibility. So the technique is performed across a wide range of settings and skill levels. And second, safety expectations. So when we perform a procedure so common like this, even uncommon adverse events become clinical and systematical significant. Now moving to the root cause of bleeding, I must say that this is rarely explained by a single factor alone. So in most cases, it results for a combined effects of patient's characteristics, anatomic constraints, technical issues. And once bleeding starts, these factors become interconnected and harder to separate. And some of these elements are not modifiable, such patient's body, anatomy of operative field, and tissue-related characteristics of the stomach itself. Others, however, are modifiable, and therefore these factors must be absolutely controlled. So this includes the appropriate choice of instruments, the use of devices with consistent and predictable performance, and adherence to technical recommendations or industry recommendations. And I also like to point out a further risk factor that I think is less often discussed. That is the tendency to perceive sleeve like a simple operation. And I must say I don't know any simple operation in obese. So this might lead to sleeve being chosen by early robotic procedures, less experienced teams, and still on the learning curve. But I don't want to mean with this that the procedure should not be performed by young surgeons or team, because we must start in some point. But I also start with sleeve, to be honest. But I mean that is when these factors are presented together, there is one more reason to ensure safety and add some investment, such as the availability of surgical instruments that are safe to use and predictable, transforming investment to clinical benefit. So when we talk about non-modifiable characteristics, what I'm referring, for example, the patient's profile. So male, as we know, presents with marked visceral fat, which makes proper exposure and visualization of vascular and visceral structures very more difficult. And exposure should never be compromised. So because this affects the safety of all the procedure. And although robotic surgery give us improved visualization and precision, this benefit alone does not offset the impact of other contributing factors. Another factor important that I think is age, because we increasingly operate on older patients. So we also face a higher risk of vascular and fragility, as well comorbidities and some medication that increase the likelihood of bleeding. Anatomy and surgical exposure are also determinant of technical difficulties in sleeve gastrectomy. So the procedure requires extensive dissection in close relation to the gastroepiploic branch in the beginning and the short gastric vessels to and the spleen itself in the upper part. And in this setting, visualization is critical and depends heavily on continuous hemostasis and a clean field. And when we combine this factor with a long staple line, another important issue that are also related to predictable instruments like a staple device, even minor technical imperfection may translate in a clinical significant consequences. Even without a catastrophic hemorrhage event, so we can see how suboptimal visualization can compromise our desired surgical maneuver, and how the selection of use of appropriate instrument and even the execution of proper technique is fundamental for time consuming, for preventing team fatigue, for safety. So this is where technical pitfalls matter, because many failures are preventable. And the most frequent technical errors include what? Include time pressure, we are always running, as well as more aggressive and abrupt movements, which are further exacerbated in robotics. So overfilling the instrument's jaws or applying insufficient compression are also short activation time, premature cutting, or sealing under tension. So overheating risk, repeating seals on the same spot, or working in the bloody field, what I'm used to see blinding energy. We don't want that occurs. And I like to think the bleeding risk as a two-phase problem. So the first, there is an intraoperative phase that is mainly what we are being discussing so far, then become the post-operative phase. And at that point, bleeding may be worsened by hypertension or by the need of thromboembolic prophylaxis, that is everyone perform in the postoperative phase. So, but many cases, the postoperative bleeding is not an entire new event. It is the consequence of incomplete hemostasis during surgery, because as we know, hematoma formation may itself sustain ongoing bleeding. And why can even minor bleeding in the obese patient be catastrophic? Because in sleeve, the issue is not simply the amount of blood, it is the loss of operative field. In sleeve and all kind of surgery, if I allow to. Once visibility is compromised, any attempt to regain control becomes more difficult, especially if energy is applied or hemostatic maneuvers are performed in the area that is no longer clearly seen. At that point, technical stress rises, operative time increase, the decision making often deteriorates under pressure, and this may lead to conversion, really nightmare, a more aggressive hemostasis and excessive reliance on multiple hemostatic agents. And the problem does not necessarily remain localized, because bleeding can spread into other areas and become a much bigger problem and complication. That's why the issue for me is not the volume of the bleeding itself, but the loss of operative field. And it is exactly the point of which obese patients really show how special they are and fully reveals its impact. Once hemostasis fails, the patient may enter a complicated cascade: hematoma, transfusion needs, inflammation, delayed recovery, reintervention, sometimes even ICU admission, and unfortunately some death. And all of this can begin with initially seemed to be only a minor technical imperfection. From there, the impact increase to prolonged hospitalization, consuming blood products, additional procedures, higher cost, and even medical legal consequences. And if I could choose one sentence I would like to remember and the end of this presentation was this: an imperfected vessel seal is not a minor technical detail, is a major clinical event. In the high volume operation like sleeve gastrectomy, rare never means irrelevant because the downstream clinical, logistical and economic consequences are really bigger than began as a small technique failure. If the incidence remains minor than 60%, high procedure volume translates those percentages into a substantial number of patients. That's why reliability is a fundamental requirement. So hemorrhage does not remain a single event. It changed the entire case. And in robotic sleeve gastrectomy, preventing that cascade means investing from the start in meticulous technique, reliable vessel sealing with predictable performance and low thermal spread for young, but that also experienced team for efficient procedure. So precision is really valuable, but reliability is fundamental. And robotic may enhance precision and ergonomics, but it also increases our dependence on reliability energy performance. Especially when technical feedback is reduced, safety depends more on visibility, control, and consistent. So if my presentation made the problem, the following presentation, I think, will address the solution, showing how innovation and technology can ensure safety and predictable performance. So thank you.
Thank you so much. I was just going to open to the rest of the moderators and see if they have any questions.
Yeah, I have a comment and a question. Excellent talk, Isabel. I think, you kind of touched on most of the issues that could happen. I mean, one comment is, we see people that, talk about doing like less arms for the robot, like 3 arm sleeves and compromising the exposure. And one thing I, always tell our fellows, we have 2 MIS fellows, is like, don't compromise the exposure regardless. An additional port is not going to add any, harm to the patient, but not having good exposure and having bleeding would harm the patient. What do you tell to your residents or trainees? Like, how do they navigate that in the world of marketing and people saying, oh, I do a 3 arm sleeve, I do a 2 arm gallbladder, that kind of stuff? How do you navigate that with your trainees, and what's your advice to them? And then the second question is, what do you think about reprocessed instruments? We're having, like, in the United States also now, we're having a lot of talk about companies that reprocess instruments, even robotic instruments, to reuse them. Do you think that's a compromise, or is that something that should be acceptable? What's your vision on that?
So responding to the first question, I must say we use in my hospital, my institution, yoga res, and we always start with what the yoga res gave us, the 4 arms and the energy that was in the beginning with device with monopolar and bipolar, and we never compromise the visualization, and we use in all cases the 4 arms, okay, all. And so I'm absolutely agree with you. So visualization will never, should never be in compromise. And it is not one more addition with 1 port of 8 millimeters that make, okay, it could be make the difference, improving the visualization. So I'm absolutely in agreement with you. About the reuse of the instrument, so I must say maybe the most safety answer. So if the industry recommendation is not to reuse, so it's better to follow the indications as they ask us to say is much safety, and even for medical legal consequences, I think it's more safety to do what they aimed to do.
Thank you, Dr. Mesquita. Excellent talk.
Thank you.
My question is about smart technology. And what do you think the impact of smart technology and feedback, such as haptic feedback, will be on improving the use of vessel sealing and decreasing bleeding?
Okay. Everything that technology gives us, I think it should be in the next presentations, that topic. But everything that we can gain with the improvement of technology is better for us, but especially better for the outcome of our patients. So we must use, if you have the opportunity, to use that new technology and improving the what you have today. Yes.
Professor Bernante, do you have any questions?
Yes, got a little question for Dr. Mesquita. Excellent talk, Isabel. Thank you very much. Do you have any strategy to improve hemostasis on the staple line?
Well, like in the vessel sealing, following what are the requirements for the instruments, the industry recommendations. So go slowly and adapting the staple with the stomach that we have. So we change sometimes the staple characteristics, of course, in the first staple line, and then in the thinner part of the stomach, we change with a more adequate staple. I don't know if I answered.
Any use of buttress material, something like that?
Sorry, with a?
Do you use buttress material, something like that?
No, we don't. We don't add anything above the staple, no.
Okay, thank you so much.
Yeah.
Great. Well, we'll move on to the next speaker, and Dr. Takla is going to be introducing that.
All right. No, thank you, IBC and Harris, for the pleasure of being here and moderating. It's my distinct pleasure to introduce our next speaker, Dr. Gabriel Diaz. Dr. Diaz is the Chief of Gastric, Bariatric, and Metabolic Surgery at Althea Foundation in Spain, and he's going to talk to us about the current landscape of robotic vessel sealing technology. Dr. Diaz, take it away.
Hello, thank you for your introduction. It is for me a great honor to be here among all this faculty and everybody who is engaged in this webinar. So this next talk is focused into go through what is out there at the moment in terms of vessel sealing and robotic technology. I do have to disclose that I am a proctor with the Hugo Ras platform. However, I have not received any economic compensation to do this presentation, so you should have that in mind. Why vessel sealing matter? Why is so important? Why are we talking about this? If we summarize this into a single sentence, it's because it just makes us more efficient surgeons. The vessel sealers has been invented and evolved in order to help us create complex operation, preserving efficiency, and especially what is safe for our patients. So as Isabel was mentioning, vessel sealer is really important to minimize the bleeding, especially in those difficult anatomical areas when we're performing laparoscopic surgery or robotic minimally invasive. If you have your surgical field full of blood, you will lose control and you will increase your complications. And especially this tool has allowed us to perform more precise dissection by minimally invasive approaches. And of course, all there combined will lead to improve the operative efficiency, faster operation, better outcomes for our patient while preserving safety. So what are the key requirements for those tools? They are our good friends, but they need to have some characteristic in order for us to be able to perform great operations. So of course, they should be reliable. They should be able to do their job by sealing the vessels in a quite efficient and appropriate way. Really important to have a controlled thermal spread, because while they induce some heat to produce the sealing, that heat should not be enough to produce injury to the surrounding anatomical structures. So it should be, they should have a controlled thermal spread. They should be efficient. The same instrument ideally should be used for traction, for vessel sealing, for exposure, handling tissue, and dissection, and therefore reduce the instrument exchange and will make the operations just faster and efficient. Ideally, they should be integrated with the robotic platform. We know that we will go through in the next slide. Some platforms don't have integrated advanced energy. So in order to do the operation, you need your bedside surgeon to use the standard laparoscopic instrument for those steps of your surgery. And then finally, they should be articulated, because the articulated vessel sealers will let you to have a wider range of movement and therefore go with all those advantages of the robotic operations. So overall, these are all the main characteristics for modern energy devices. So how do they work? Overall, there are three main mechanisms. The most popular and most frequent is the bipolar radio frequency. What they do, they compress the tissue, they induce the radio frequency, and this leads to collagen and elastin fusion, and it creates the sealing of tissues. The other mechanism is the ultrasonic, which basically the two blades of the device start vibrating in a really high speed, and this leads to protein denaturization, and it produces the vessel sealing. And there are some instruments out there that combine both technologies in order to try to be more efficient. So this is a summary of the main robotic platforms out there at the moment. As you can see, Da Vinci, Hugo, and Versus, they have integrated advanced energy. The other two platforms out there that are being used, which is Tomai and Mantra, they have only standard monopolar and bipolar integrated, and if any procedure needs advanced energy, it should be done by the bedside surgeon with standard laparoscopic instruments. So let's go through all these instruments one by one. The vessel sealer extends is from the Da Vinci platform. It has the capacity of use bipolar radio frequency. With this, you will seal the tissue, and also has a blade will be in charge of the mechanical cutting. This is an instrument that can be used for grasping. The section is quite versatile for during your robotic procedures. And the wrist, it has a great range of movement, 90 degrees, which is great for especially, complex operations, small spaces, etc. In terms of performance, it has the capacity to seal vessels up to 7 millimeters in a 3-second time. The burst pressure, which is the pressure that is necessary to break the seal of the instrument, is up to 3 times of the systolic pressure, which is quite reliable in the clinical settings. And the thermal spread is quite small, it's up to 2 millimeters. Specifically, this instrument, the advantages is that it has the capacity to seal larger vessels. We'll see that the other goes up to 5 millimeter top, no more than that. Great articulation up to 90 degrees. This is one of the instruments with great range of movement. And particularly, I like the idea that both of the jaws will move. So when you're using this instrument to perform the dissection, I felt it, for example, when I was using the robotic platform, use your standard Cadier or bipolar, both of the jaws are moving, and you kind of get used to this movement for your dissection. If your advanced energy device only move one jaw, it's appropriate, but you find yourself sort of more clumsy if you don't have both those movements. But this is just like a personal preference. All of them, if you know how to use it, it should be fine. Considerations about this device. It has relatively bulky jaws. This is one of the bulkiest jaws of the instrument that you will see. And of course, for the workflow, you have to seal, and then you need to activate the blade and cut, and therefore the whole workflow of the instrument is tiny. If you compare with other, it is slower. So in a clinical setting, this video is back from 2019 when I was working in Cleveland Clinic, Abu Dhabi, with my mentor and great friend, Ricard Corceles. We were performing here a revisional study, sleeve to study. This is like kind of like the old version of that vessel sealer. What you can see has like a bulky, quite large jaw. However, this instrument at the time was appropriate to perform the section. You can be quite delicate. You can perform sealing or large vessel, or even like small. You can see here the pancreatico duodenal vessels. You can be able to control them appropriately with this instrument. It's just that you can see if you are navigating in a small reduced space, such a bulky instrument takes the vision from you. So Ricard was kind enough to share with me this video, which is the current version of the vessel sealer. This is one of his fellows also doing a robotic study. And we can see just like an optical comparison how those tips have evolved and how do they behave. So it's like a smaller tip. It takes less space in those reduced anatomical surgical field, but still you can perform, delicate dissection, control small blood vessels, and they are appropriate and efficient in terms of, specifically now, bariatric surgery, metabolic and bariatric surgery. Now moving forward to the other surgical vessel sealer that is out there is the SynchroSeal. SynchroSeal is also from the Da Vinci platform. It also works with the bipolar, but this device has the capacity to do simultaneous sealing and transection. So the workflow is somehow more efficient. This instrument also, as the other one, can be used for grasping and dissection, but the articulation is less. If you remember the previous tip, we were able to do 90 degrees. We are doing 60 degrees now, so has less free of movement. Performance, it can take vessels up to 5 millimeters. So you can, if you remember the last one, it was 7 millimeters, but it's smaller, tiniest vessels, but it's faster. It's up to 2 seconds. The burst pressure is quite efficient, well above the physiologic pressure. As you can see here, the thermal spread is slightly smaller than the standard vessel sealer. What are the advantages of this tool is that it's a single step seal and cut. It's more efficient, fast activation times, and actually the peak, the temperature in the jaw, the peak is quite shorter, so it cools a little bit faster. So that can be an advantage when you have to grasp a tissue that you're not necessarily going to transect. Consideration, my own personal preference, that is just a single jaw moves. So you are kind of missing that diversity and the advantage of the robotic platform where both of your jaws will move during the dissection. If we look in the device in a live case, this is from the Intuitive website, an official video. You can see they're using the SynchroSeal during a gastric bypass. It's quite fast, single step. But there's, I don't know if this specific case, there's some tendency of less clean dissection, some sort of vessels that are bleeding and oozing. And I was curious about it. So I spoke with some of my colleagues that are regular Da Vinci user, and they mentioned like almost all of them were using the standard vessel sealer. They were not using the SynchroSeal. They didn't like it that much. We can talk later if there's any other Da Vinci user here connected. They can talk about their own experience. If we look into the clinical data overall, this instrument has been used in all kinds of operation with appropriate outcome, and some comparative studies mention that they just perform appropriately. There's no increase of complications. All you have to do is know how to use your instruments. Now we're moving forward with the Hugo RAS platform. This is the platform that I currently use. We have it available since December last year. This advanced instrument has been introduced in the market like quite recently. So as you can see in the picture, it's a straight instrument, curved jaw, works with the bipolar radio frequency energy. And it's a great instrument for grasping and dissection. What I like is that the tips are fully covered. So that's great for the thermal spread. It goes to up to 7 millimeter vessels. They can control them, and it's also quite efficient. In 2 seconds, they have done the sealing. The burst pressure similar to the other tools, up to 3 times the systolic pressure, and thermal spread only by few millimeters, but it's one of the less thermal spread, theoretical thermal spread at least. Personally, I like the curved jaws to perform the dissection. And when I moved from my laparoscopic procedure to the robotic procedures, I was just using the same tip. So in my mind, it was the same operation that I was using. Although it doesn't have the articulation. It's a non-wristed instrument. To me, I was familiar and I've been able to do all sort of procedures. Something, if I can wish, the perfect instrument will for both just to be able to move, just so I can have those extra maneuvers during the dissection. So in this video, this portion is exactly non-edited, so all of you can see in a case, this is a primary SARI, and you can see how the ligature RAS behave for control the vessel sealing, especially here in the short gastric vessels. All of us know how important is this during a sleeve gastrectomy. This tool also is quite appropriate to handle the tissue. And here we can see that curved jaw to how it helps to perform the dissection, especially here at the duodenum. The thermal spread looks quite appropriate. And actually, in my unit, we perform not only metabolic and bariatric surgery, we also perform benign and malignant pathologies. And all of you can see here that ligature RAS, how it behaves during a radical lymphadenectomy. This is a case of a gastric cancer. We are mobilizing the lymph nodes from above of the pancreas and the hepatic artery. And I find myself quite comfortable while performing like handling tissue, performing blunt dissection, sealing vessels really close to the hepatic artery and not being especially concerned with the thermal spread and our experience at the moment. We have it since December, but we are quite happy with it. We haven't had any issues. It's as any other minimally invasive procedures. And lastly, the ultrasonic dissector. This is from the Versus platform. This is also this has been available since quite recently. At the difference to the other instrument that we have spoken until the moment, this has ultrasonic technology. The good thing is that it has simultaneous sealing and transection, as all of the other instruments can be used for grasping and dissection. But what happened is it takes vessels up to 5 millimeters, and it seems to be relatively slower than the other instrument. Burst pressure is appropriate, well above the physiologic blood pressure, and thermal spread is great. Something that is good about this instrument is small, so the jaws are tiny, and this could be great for reduced working spaces. But we must have in consideration there is a non-wristed instrument. Again, personal preference, single jaw moves. We need to have in mind that the ultrasonic technology, so there is a hot blade that you need to have in mind, so don't have inadvertent injuries. And in theory, this is the one with the longest sealing time among all of the available vessel sealers. And this is just for optical comparison, where we can see all the advanced robotic sealers that are out there at the moment, where we can see the Da Vinci they're great because they have articulation. You can have sealing and cutting, or sealing and cutting at the same time, but these tips are relatively bulkier than the newer ones that are non-articulated. For the new ones, they have the capacity to have great sealant performance, thermal spread, and the small instrument can be great for some steps of the operations. So overall, what are the current limitations of these robotic vessel sealers? The vessel size is limited up to 70 millimeters, so we still need clips or other kind of homologs or stapler to control larger vessels, like for example, the left gastric artery. Device bulk, you can see 50% of the instruments that are out there, they have larger or bigger jaws. So for some procedures, it can be inconvenient. Not all of them should be articulated. Ideally, if you have a robotic platform, you love your instrument to be articulated, to have the whole range of movement and have all the advantages of using your robotic platform. And something that you guys brought before is that all of them are single use. Ideally, if we could reuse them, there will be a potential economical and also environmental impact in a positive way. So as a take-home messages, just to wrap up this presentation, there's no doubt that the vessel sealing is essential for us surgeons, especially in robotic surgery, for us to be efficient and preserve safety. If we take a look, if we remember all the instruments that are out there, most of them use bipolar radiofrequency. There are two instruments that dominate the field at the moment, but it's because they are used from the platform that has 20 years of evolution, which is the vessel sealer extend, the Cycroseal, and the newer system as the ligature and ultrasonic dissection. They look promising because although they are not articulated, they are quite small and they perform quite well clinically. So they do have potential. All of them have unique profile. We must be familiar with it, so we don't have any intraoperative incidences. And all surgeons must be well aware with the characteristic and limitation of the energy devices to have appropriate use. Thank you.
Thank you, Dr. Diaz. It's an excellent talk, giving us the landscape. And thank you for mentioning the strong environmental impact of robotic platforms and these single-use devices. Fantastic. Are we reaching a point of diminishing returns with our current vessel sealing technology, or do you still see a paradigm shift ahead for us?
I do feel that there is still some room for improvement and for efficiency. If you ask me if I can ask like the typical 3 wishes, I will love to have a feedback. So when you are dissecting those large vessels, the platform can tell you, listen, be more delicate because you can have a vascular injury. Or for example, before cutting, it doesn't let you cut if the vessel is not completely sealed or if you went halfway through it. And or if you can integrate a CT scan with your patient in the robotic platform, and it can help you navigate a complex bariatric operation or a lymphadenectomy during a gastric cancer, that will be ideal. I can see all those things happening. They should happen in the future.
That was a very good talk. I learned a lot from it. So thank you for being
Oh, thank you.
And kind of following on Dr. Johnson's question, if you have a crystal ball, where do you think this sealing, vessel sealing technology will be in the next 5 to 10 years? And also, how would artificial intelligence and automation, what is the role of that will play in vessel sealing in terms of improving precision and safety?
Yeah. So, as I was saying, all these instruments, they are here to help us to be faster, safer, and efficient. So in my mind, I would love to have like a multi-port articulated energy device because all of us know that at some point we need those jaw of advanced energy, but at some point we also need the monopolar. So we can have all that integrated in a tiny multi-port instrument that will be great for in terms of energy. And if we can combine that to reuse, we can decrease, the environmental impact and economical impact. That will be great. And of course, I think that integration with the AI and simultaneous navigation, I think it should be the near future with the robotic platform. Because if we look into the data, it has been so difficult to show like a strong, significant difference in terms of clinical outcomes for our patients when we use robotic platform. If we have these tools integrated, I think we should be able to demonstrate that different for sure.
I just have one quick question, Gabriel, if you don't mind, Hany Takla. So what is your experience in using vessel sealing devices on making enterotomies in the bowel? Like, if you're doing a Diaz or a SAD and, opening the duodenum with it, or small bowel for JJ or something like that. Do you use it for that? And then does that help you save like a spatula or scissors to make the enterotomy, or does that make sense?
Yeah, when I was doing a laparoscopic procedure, I used to have even the advanced bipolar or advanced ultrasonic with the hot blade, when you can do the enterotomy and you save and exchange instrument. But I have the robotic with the bipolar, so I do need to change the scissor with the monopolar, because I like to have the control with the articulated tip, and then I move with the needle holder to do the anastomosis, for example. So I do need to do an instrument exchange there.
Thank you, Dr. Diaz. I've got a little question for you. And what's your opinion? In my opinion, we can distinguish two different sides of surgery. The first one is vessel sealing, for example, in bariatric surgery, when we need to have energy device that take a large bite and do a good hemostasis. Another side of surgery is thorough anatomical dissection through fascial planes, like as you show us in a good video during, for example, D2 gastrectomy, so a lymphadenectomy. In my opinion, in this kind of surgery, when I do a D2 lymphadenectomy, I prefer to use monopolar and bipolar to do a thorough dissection. What's your opinion?
That's a great question. I'll tell you this. When I first started using the Hugo, the advanced energy was not out there. So I found myself in a clinical situation when I need to revisit and be familiar again with the standard monopolar. And I started loving monopolar with scissor for dissection. It's great because you don't seal the plane. You can see it really well. You have great control. The tip is good for the section. But once I had available the advanced energy, I do feel that it can have an impact in decreasing, for example, the lymphatic leak. The bleeding you can control with the standard bipolar, standard monopolar, bipolar, but that tiny lymphatic vessels, the advanced energy, you do need it for that. And I found myself, we've been able to perform appropriate lymphadenectomy, both with advanced energy and standard monopolar, bipolar. And not every case is the same. Some patients, they have this kind of like fragile tissue that doesn't perform well with the monopolar. Those patients with a fragile tissue, I do prefer advanced energy to be more efficient.
Thank you very much, Dr. Diaz. Excellent talk. It is now my pleasure to introduce our third speaker, Professor Marco Raffaelli from Italy. Professor Raffaelli is head of the Division of Endocrine and Metabolic Surgery at the Fondazione Policlinico Universitario Agostino Gemelli, IRCCS, Rome, Italy. He's also full professor of surgery, Università Cattolica del Sacro Cuore, Rome, Italy, board member of the Italian Society of Surgery for Obesity and Metabolic Diseases, director of SICOB Postgraduate School of Bariatric Surgery. And he will give us a lecture on innovations in robotic vessel sealing technology, bridging surgery with science. Thank you, Professor Raffaelli.
Thank you very much for your kind presentation. It is really a pleasure and an honor being here with you tonight, this evening. I have to say that in spite of that, I've changed a little bit my presentation during the presentation of Dr. Diaz, because he stated that to my platform doesn't have any energy device so far. I've experience also with my platform, so I put a small video focusing also on the harmonic that to my platform has. However, my focus will be in the new released energy device we have, particularly the ligature Maryland Rust that has been released just at the end of the last year. However, if we look in the literature, as Dr. Diaz showed, there are some comparison between new and not new energy device in bariatric surgery. And the most recent one was this published in 2022, comparing at that time the new release synchroseals with the harmonic case in the animal model, showing that radio frequency could be considered a little bit better in terms of sealing time, sleep force, sleep pressure, etc., with respect to the laparoscopic harmonic case, not the robotic part, and that the synchroseal, which is a radio frequency with radio frequency cut, may reach a burst pressure of around 360 millimeters of mercury. That means 3 times the systolic mean blood pressure. But when compared with the older radio frequency energy device that the Da Vinci platform has, even if the curved shape and some technical details may render preferable in the hands of some, as Dr. Diaz says, most of it looks like that the vessel seal extent seems much more efficient in real life when performing bariatric procedures. And this is my personal experience, because with the Da Vinci platform, when I have to choose an energy device, I usually choose the vessel sealer. For sure, this is very efficacious in achieving hemostasis, as you can see in this in this video. But maybe it is a straight shape, and the branches in some kind of dissection, as Paulo underlined in his comment just before my presentation. It can be preferable thinner instruments to achieve a dissection. That is not usually the case when dealing with bariatric surgery. With respect to Hugo Ras, that have been using since the beginning, starting before the CE mark for general surgery with adrenalectomies, and started very early in March 2023 the experience for bariatric surgery. As we have demonstrated in our experience, it is very useful, and it allows a very simple learning curve for both experienced surgeon and not experienced surgeon, and the results are quite close to those of the Da Vinci in terms of outcome of patients undergoing Roux-en-Y gastric bypass. However, the platform has still some disadvantages, even if, because it is advantage in terms of vision, suturing, modularity, sustainability, etc. But there are still some advantages, and one of these disadvantages was till last September the lack of energy device instrumentation, and this some way limited, at least in my experience, the possibility to use this platform for more advanced surgical procedures with respect to Roux-en-Y gastric bypass because of the lack of vessel sealing system. And indeed, this instrument was released in September 2025, was the first robotically driven ligature instrumentation. It has the same characteristics as Dr. Diaz showed as the ligature in the laparoscopic counterpart. It is effective with cold cutting with a blade with cut. It allows a secure automatic grasping, but most of all, it has carved jaws that allow for improved access over striped jaws. That is true. However, we have to underline once more that the instrument is striped and non-curved, and this limits in a certain way, even not so much, its application in the operative field. I have to say that I brought with me the first three operations in which I used this instrumentation in my practice in early September, in mid-September 2025, as I did for the Hugo platform. The first operation in which I used this device was an adrenalectomy, just to show how confident we can be since the beginning with this instrumentation. I didn't fear of sealing and cutting main adrenal vein in this very difficult caching, adrenal caching patient that, as you can see, has very fragile tissue that may cause some minor bleeding, but the instrumentation is very efficient in achieving hemostasis. As you can see, I did and very fast and effective. I have to say that the speed of the video was increased to 4, so this is a 4 speed videos, but just to show how efficient, without editing anything, is this instrumentation. And this was demonstrated very efficient since the beginning, because this was case 1 in which I used. The second operation, sorry for my voice, and this is the end of the operation. Case 1 went well, no bleeding at the end, even if this is a very fragile Cushing syndrome patient. The second operation was a Roux-en-Y gastric bypass, which represents most of the surgical procedure I and my team performed with the Hugo platform. And I put in comparison with the standard technique. While in the left side we have a more difficult case, and as you can see, the step we follow are always the same while preparing the gastric pouch, the Roux-en-Y gastric pouch. It looks like evident that the patient on the left side is a little bit more difficult than the patient on the right side, which is a standard 40 kilogram per square meters patient, while we have a 50 of BMI patient on the left side. As you can see, the also in case 2, the ligature was effective and safe in preparing the gastric, in helping preparing the gastric pouch, even in a little more difficult patient. And as you can easily see, it results in achieving a good hemostasis, but also in reducing some way the operative time needed for dissection in more difficult cases. And also in combination, in this case, a small bleeding of bipolar cautery, it is very efficient instrumentation. But what I like it most, as I will show in the next video, is in sleeve gastrectomy. I have to say that before the introduction of also in this case, the speed is 4 times the real speed. I've never approached a patient with the Hugo platform for a sleeve gastrectomy because of the lack of energy device. I don't like bedside energy device using. We change a little bit with respect to Roux-en-Y gastric bypass, the setup of the Hugo platform. And as you can see, and also Dr. Diaz showed, it is particular in this kind of dissection that we have the advantages of an energy device. Even if the speed is 4 times, also in this case of the normal speed, you can see that in an unedited video, the instrument is really efficacious and, let me say, safe in achieving the gastrolysis in this for sleeve gastrectomy. As I told you, this is a real-time video, so this unedited videos, just to show which are the opportunity that this kind of instrumentation may give in real life, also with the robotic platform. And as you can see, no assistant help from the bed is necessary, and we will introduce only following the end of the dissection the stapler from the bed, because as you know, Hugo platform hasn't any robotic stapling system yet, but I hope it will have in the future. And even if there is no articulation, if the setup of the platform is performed in a good way for the procedures we are going to do, we don't have any issue in achieving complete gastrolysis thanks to the utilization of very efficient instrumentation. So, at least from my experience, LigaSure Joe is really effective and safe. It is efficacious, at least in my experience, in reducing operative time for both one-wide gastric bypass, but also for sleeve gastrectomy. Maybe it can extend the indication to other procedures, including with respect to the previous experience, including SEDIS, Diaz, and transit bipartition, and it is still in the trend toward a solo surgery, which at the end of the day is the aim of robotic surgery, not rely necessarily on the system additive. Then, as I told you, in the spirit of TRAT, I put this last slide just to show you that the ToMai platform that I also use all together with the Da Vinci and the Ugo platform as this ultrasonic energy device, which is TRITE. I have to say it is efficient. I don't like to use in obese patient harmonic energy, but I have to say that this is a good quality instrumentation. So thank you for your attention, and thank you for the privilege of being here this evening with you.
Thank you so much, Professor Raffaelli, for this talk. My question is about where we're going with the science of vessel sealing. Are we really advancing, or are we primarily refining existing technologies without fundamentally changing our outcomes? What are your thoughts?
Robotic platforms so far, or at least have introduced this technology we are using in our laparoscopic activity since many years, because it's much more difficult to design instrumentation like that. But I guess that with the advances in this field, we'll have, and we already have in our hands, very safe and useful instrumentation in the everyday practice. I rely a lot in this kind of instrumentation in my practice, and I'm happy to use them. The only issue is price. As Dr. Diaz underlined, being not reusable, being single-use instrumentation make the cost quite high. And in terms of sustainability, not all healthcare systems can afford this kind of instrumentation, and not all the procedures can be reimbursed in terms of making this instrumentation affordable, even if they're very useful. And sometimes they can have multiple use. Not only it can be also to grasp a tissue, to cut, as you said. Energy device are an advancement also for the robotic platforms, at least from my side. For sure, in certain circumstances, we need monopolar or bipolar cautery, but having an efficient energy device is a must also for robotic surgery.
Thank you, Professor Raffaelli. Great videos, and the Maria tip ligature is actually one of my favorite instruments. We don't have a robotic platform for it. I usually use it for my laparoscopic sleeves. I noticed a couple of things. I noticed that you waited for a little while just to see if anything was bleeding, and then you went and you saw a little bleeder and you actually coagulated. But do you ever desufflate to just kind of, do you have any tips and tricks for that? And my other question is, what role will, as we're talking about innovation?
I miss your first question. There was a problem with the connection I had, maybe.
Oh, okay. No, I was just letting you know that I noticed that you waited for a little while to check for any hemostasis, and as you saw that there was a blood vessel, you went and coagulated that. But do you have any tips and tricks? Do you ever desufflate for like a couple, like for 2 or 3 minutes just to make sure that everything is hemostatic, and then you insufflate back? And my other question was, if we're talking about innovation, what role will personalized medicine play in tailoring vessel sealing to individual patients, if any? What do you think?
First question, for sure, at the end of any operation, we reduce the insufflation to look for bleeding. This is a must in clinical, in current, in everyday practice. Also with the robotic platform, we usually use lower insufflation pressure. That means we can work at 8-10 millimeter of mercury of insufflation, so make a little bit even easier to check for hemostasis at the end of the operation. This is thanks to the lift of the abdominal wall we can obtain with the robotic arm. With the second question, the personalization of utilization of instrumentation, again, I usually face obese patient. So my favorite instrumentation is radio frequency instrumentation in obese patient, for sure. I don't like, as I already said, ultrasonic energy, harmonic energy in obese patient, while it is very useful for dissecting in cancer surgery. So, and also lean patient may benefit more of very thin jaw, while very large obese patient or retroperitoneal fat may benefit more of large jaw to achieve a good hemostasis. For sure, it depends on the patient and the disease, on different things. Having the possibility and the capabilities to shift from one instrumentation to the other, from one robotic platform to the other, one from the laparoscopic approach to robotic, or from the robotic maybe to the laparoscopic approach, give us the opportunity to tailor the approach, the instrumentation to the patient disease we have to face.
Great, thank you.
Hi, Marco. Nice talk, as usual. I have a strange question for you. And if you have a magic wand, which is the energy device of your dream, do you have any preference, any desire for the future?
Articulated instrumentation, radio frequency. I don't know if a Maryland shaped or stride shape. It depends on the patient we have. In most of obese patients, stride instrumentation may have some benefit, but having the possibility to shift from one curved and one stride would be better, but my preferred instrumentation is radio frequency, possibly articulated.
Great. It is my pleasure to introduce our final, least but not Our final speaker, Dr. Dilendra Weerasinghe. He is a director of bariatric surgery, Rochester Regional Health in New York, USA. He will be speaking on robotic vessel sealers and future development opportunities.
Thank you to IBC for inviting me for this talk, and this would be somewhat a summary of everything else which has been discussed earlier. Can you see my screen, or?
Yes.
You can? All right, great.
Doctor, please put it in the presentation mode, please.
Perfect. Can you see now or no?
Yes, we can.
You can. In presentation mode, you got?
Yes.
All right. So the question that we have to ask ourselves is why vessel sealing matters, and I think this has been quite well described by our previous speakers, but just getting on to a little bit of a nuance, precise hemostasis is the key behind successful surgery. If you can control the blood vessels, you can control the outcome, right? That's true for any type of surgery. But as we move along, speed and safety go hand in hand. You want to have a device which can satisfy the speed in which you can perform this surgery by getting good, reliable hemostasis, but at the same time, it has to be safe as well. A good vessel sealer should minimize the collateral damage. There's always going to be some thermal injury to the surrounding tissues, and this has to be minimized. And the instrument that we're talking about would have to have a lot of versatility, and this would lead to minimization of instrument exchanges, which in turn would result in a faster operation. The challenge as we look towards the future is that the current devices are still energy tools rather than intelligent platforms that we could work out of. So when we talk of the robotic revolution, if you try to understand that open surgery was where we basically cut a person open, felt the tissue, could apply pressure directly. We use different types of techniques to attain hemostasis. And for a very, very long time, this was a very effective way of doing surgery and reducing the levels of complications. But a bigger incision, putting your hands in there and trying to control hemorrhage, the old-fashioned way meant that the inflammatory response was much higher, thereby the recovery of these patients took a bit of a downturn. And it was revolutionized when you could perform these same surgeries with smaller access holes, reducing the levels of inflammation, faster recovery. Now, when we come into the era of robotic surgery, we have now put a computer between a television screen, which with laparoscopic surgery is mainly tele-assisted surgery. Now we put computer-aided telesurgery, giving us real-time 3D visualization, putting in a computer to analyze some of the things that we're doing. And in the future, we can have image overlay AI assistants to help improve our outcomes even further. So let's go back to the engineering principles of vessel sealing. To get an effective seal, we need to compress. We then generate heat and apply that heat for a certain amount of time. If we use too much heat or if we apply the heat for too long, that can cause problems with the ultimate collateral damage to the surrounding tissues, or it can actually compromise the seal itself. So controlled energy delivery is also very, very important, because when we start applying energy, the tissue structure changes, the impedance between the two tissue jaws change, And therefore, if you want to manage the optimized change of the coagulation, or what we call coaptation, then the energy has to be constantly changed, or the wattage of electricity passing through the two jaws have to be changed, and this has to be recognized real time. All this thing will lead to soluble proteins, collagen, fibrin denaturization, the same thing which happens when you boil an egg, where a liquid protein now becomes a coagulum or a solid structure, which ultimately forms a permanent vessel seal. So this is kind of some of the science behind the sealing. And again, this shows clamp, application of correct energy, generation of heat, denaturization of the protein, vaporization of the fluid, and giving a proper seal, resulting in a sticky coagulum. So once again, correct compression, correct power, precise timing, the angle in which you approach a vessel, all of these things are very, very important in a successful and reliable seal. And therefore, when we look at the future of vessel sealing, all of these aspects need to be addressed. So now if we take a look at the latest vessel sealer, which is compatible with the DV5, this particular the vessel sealer curved has superior sealing technology up to 7 millimeters, and this is the first in its class to be approved for dissection and transection and sealing of lymphatic vessels. So we had previous discussion about what the best tool to deal with lymphatic tissue. This is the first in its class for its lymphatic vessel sealing. This vessel seal also creates a very good seal, up to 3 times systolic blood pressure. So that translates to around 400 millimeters of mercury. Multifunctionality is also very important, where the device can be used to grasp, dissect, coagulate, do everything like once, with minimizing the amount of instrument exchanges. And the precision and the dexterity and the reticulated nature of the instrument is very, very important, especially in bariatric surgery. You know, when you want to get around those short gastric vessels approaching the spleen, and trying to identify the left cross, all of these wrist instrumentation, the reticulation becomes very, very important. And clearly a slimmer jaw profile becomes important for you to be able to get into those nooks and corners, to be able to apply the heat, like let's say approach a vessel at 90 degrees, so you get the most optimal sealing ability. Now, especially with this vessel sealer curve, there's very little collateral spread, maybe just around 1 to 2 millimeters of lateral thermal spread. So therefore, surrounding tissues don't get as much damage as with the previous generation, and it also has faster cool down, and it's much faster, twice as fast as the vessel seal extend. The amount of camera cleaning also is improved, because the amount of water vapor and all of that which is generated becomes less as well. So having said all of this, the current limitations of the current generation vessel sealers, including the most advanced vessel sealer curved, is still there is lateral thermal injury. The seal quality varies according to the tissue thickness, and it is very, very important, especially in our speciality. Our patients have a very thick omentum, and fat conducts electricity quite poorly. As a result, there can be some degrees of compromise in its seal quality. Sometimes some individuals try to seal it twice, hoping for a better seal, but actually that's not a good thing, because that can lead to charring and not a proper seal. So there are quite a bit of limitations as we see things as they are, and the operator technique matters as well. So approaching a vessel in the wrong direction, not going right through a vessel, not dissecting a vessel completely before application of the energy. All of these things can limit the reliability of the vessel sealer. Of course, the instrument exchanges are still needed. There were questions before as to whether we can use the same device to make an enterotomy. All these things come into play when it comes to trying to improve the next generation of a vessel sealer. What was highlighted in the previous speakers as well, the cost and the disposable instruments, which current generation vessel sealers are all disposable, and that puts a huge burden not only on the cost in terms of the amount of money paid, but the environmental impact that it creates as well. So trying to look to the future and produce the reproducible, reusable, non-disposable items would be a great boon to the future of surgery. So now let's take a look at what can be done and what should be done going forward. And thanks to the compute ability of the robotic systems and the generators, real-time tissue impedance, the amount of collagen, the calcium within a vessel, the vessel diameter, the tissue hydration, all these things can be calculated. One of the speakers talked about haptic feedback. Sometimes the vessels are calcified. So clearly, if the computer can detect all of this and then adjust the correct amount of energy, then clearly we will have a better seal going forward. So the future of these new vessel sealers will have advanced tissue sensing, impedance sensing from the jaws, AI recognition of tissue. So for example, as our camera goes in, and if it sees that it's dealing with fat tissue, it'll adjust very quickly the energy settings, dealing with a higher wattage, higher power setting to overcome the impedance created by the lack of conduction through fat tissue. If the dissection, if there is image overlay, which if a previous CAT scan has been loaded into the system, and if you're dissecting a pancreatectomy or any sort of other surgical oncological procedure, it can detect where you are and apply the right amount of energy to create the seals. And that's where we could potentially see the vessel diameter going beyond that 7 millimeter mark as well. Now, as the tissue starts dehydrating, when you start applying heat energy into a tissue, there is dehydration, and the amount of the dehydration can be captured and the tissue density monitored, which can really modulate the amount of energy as this keeps on changing in very quick real time. And the haptic feedback will also allow the surgeon to understand the tissue thickness, density, and then be able to apply the correct type of energy modality as well. And again, as we said before, multi-use reusable sealing devices to keep the environmental and climate consideration. So what are the future possibilities? We can also combine, there was a question with regards to what the most optimal energy modality that one would want to choose. And the answer is there's no one right answer. For general use, I prefer RFA bipolar energy, but ultrasonic energy has its place as well. If you want to have faster cutting, if you want to use it on a individual who has maybe a cardiac pacemaker, clearly ultrasound energy may be useful as well. So how about combining all these energies together and trying to find what is optimal for the task you're performing? So the future could be that all of these are combined into one instrument, and I think that has a huge potential going forward as well.
Great talk.
So, sorry, there was a bit of a technical glitch on this side. It's all sorted. So, the integrated robotic hemostasis will detect the vessel, optimize the compression, type of energy that is required. It'll verify the seal integrity, all whilst with it being within a closed loop robotic system. And at the end of it, we'll say, the seal is very secure, it's marginally secure, or reseal is secure. So if we have this platform which will give us actual feedback, that would be huge in terms of our ability to perform surgery with reduced bleeding complication, fewer instrument exchanges, short operative times, which will ultimately improve the surgical outcome that we're dealing with. And again, in the next 5 to 10 years, we'd expect AI to guide robotic energy delivery, especially with image overlay and visualizations, and also intelligent tissue sensing. And then the next phase with multimodal energy platforms, where different energies can be used for the different situations, and autonomous seal verification, which can happen simultaneously, confirming whether your seal is adequate, and then a fully integrated closed loop robotic hemostatic system, which may include suction as well to keep the field clean, visualization better, because some of the biggest challenges that we do have is when it starts bleeding, then it distorts the image because the hemoglobin attracts a lot of the light, as well as it can spray the blood onto the camera, making it harder and harder. But if at the place where you're applying the energy, if it has a microsuction attached with that, it can keep the field clear for you to continue with it. So all of these things are in the works, and hopefully in the next 5 to 10 years, it will translate into effective product, and we will be able to use this. Finally, in summary, computer-aided robotic surgery, integrating it with smart AI technology, tissue sensing technologies, will optimize better and more reliable sealing technologies to give a predictable, automated hemostasis in order for us to perform surgery in a more successful and reliable way. Thank you very much.
Thank you, Professor Weerasinghe. That was like something that's virtual webinars can always happen. I was like, that's a very weird way to conclude the webinar. Conclude your talk, and then I had a quick question. As you're talking about like using AI and automation for vessel sealing, how can we warn surgeons about over relying on these systems as we're trying to utilize them, because they might not be perfect either? So what are your thoughts on that?
As much as we think that we are better than technology, if you really play the game of odds, technology is always more reliable than an average human. So it's like if you take the autonomous driving, right? So they do meet with accidents, and sometimes you say, how could that happen? But overall, if you take an average accident happening with an automated system, it's less likely. So individually, the beauty here is that you still have control. I think especially with haptic feedback and all of that, you still will have control of the system, and the system will just guide you, saying, hey, you know what? We don't think that the seal that you have achieved is good enough. Maybe you should consider a different way of achieving a seal, maybe either reapplying the seal or using a suture to control that bleeding, or but just give you some idea. So it'll aid in our decisions. I don't think it's meant to overtake and it's not meant to replace us. And the beauty of it is that once it has, if you especially take the Da Vinci system, which is connected to centrally to their systems as well, there's learning which is happening every single minute, right? What's done right, what's done wrong, and that metadata will ultimately result in more improved and more efficient systems, which will ultimately be translating to safer surgery going forward.
Thank you.
Did you guys see the slides? I mean, I wasn't sure there was. Oh, you did it.
Yes.
Sorry.
Professor Bernante and Professor Johnson, any questions?
Amazing talk. Really amazing talk. You have shown us what the future will have in place for us, and very, very nice talk. I have no question. I was really amazed. Thank you very much.
Similarly, great talk. It's exciting to see the improvements that are on the horizon. I suppose my question is, if you had to narrow it down to one, which one do you think will make the most impact in the next 5 years?
I personally think AI integration, it's the visual and the haptic, the feedback, real-time feedback. So the artificial intelligence that looking at the tissue and predicting, hey, now you're going to go through omentum, or you're going to go through a pure blood vessel. The AI can recognize, like the other day, my son, we have a very complicated computer rack, and we didn't know which plugs were going where, but you take a picture and tell ChatGPT to figure out where these plugs should go, and it can do that. So this technology is available where you can basically literally, Da Vinci, like with the iris technology, with the image overlay, they have the technology for them to predict. So if there's a discrepancy between, okay, this is the impedance that we are going to expect from this fatty tissue because there is a surgical clip in between, now that it recognizes that this should be the impedance going in, when there is a different impedance, it can detect and say, hey, you know what, this is what's happening, don't do it. Right now, it won't go through because it's happening at a very it's not giving the correct compression. It censors it, but it doesn't know what exactly it is. But in the future, like a calcified blood vessel, the amount of energy that you deliver won't be the same as compared with, and it will read. So as the electricity passes through, what will happen is the impedance changes as the amount of liquid or the fluid dissipates. And if there's more calcification, you can write algorithms to overcome and get a better seal. And that's what is exciting, what is expected, what's going to get in terms of real time between the jaws, and make those microscopic calculations, which will help us get a better seal. And once you get a better seal, when you get control over hemorrhage, you can do anything.
Okay, thank you, everybody. I think that it's time to conclude. We can say that we got some keywords from this webinar, and I can say that these keywords are machine learning to optimize energy delivering, multimodal energy platforms, and integrated robotic hemostasis. Probably this will be our future. And I would like to thank all the moderators and the speakers of this webinar, and goodbye to everybody.
We would like to thank the faculty for taking part in the webinar today, and would like to share this sponsored promotional video.